Somewhere between 50 and 60% of women will experience a significant decrease in sexual desire at some point in their lives. Not a passing dip, a real, sustained loss of interest in sex that affects their relationship, their sense of self, and their daily well-being. And almost all of them will spend months, sometimes years, believing it's just who they are now. I'm Dr. Maya Roa, and I want to start today by saying something clearly. Low libido in women is not a personality trait. It is not inevitable aging. It is not you becoming cold or damaged or no longer capable of desire. In the vast majority of cases, it is a medical phenomenon with identifiable causes. And in many of those cases, those causes are addressable. So today we are going to go through exactly what drives female sexual desire and what suppresses it. We are going to look at the hormonal story, the psychological story, the relationship story, and the medical story. And by the end of this video, I want you to have enough understanding to walk into a doctor's appointment with the right questions, or to have a more informed conversation with your partner about what is actually happening. Let's begin with the biology of female desire, because it is more complex than the biology of male desire, and it is almost always explained too simply or not explained at all. Male desire is relatively straightforward from a hormonal standpoint. High testosterone drives high libido. When testosterone drops, so does drive. The relationship is fairly direct. Female desire does not work this way. Women have testosterone too, produced in the ovaries and adrenal glands, and it does play a role in female libido. But female sexual desire is governed by a much broader hormonal orchestra. Estrogen, progesterone, testosterone, oxytocin, dopamine, cortisol, all of these interact, and their relative balance matters more than any single hormone in isolation. Here's the first thing I want you to understand. Female desire is not primarily driven by a hormone saying, "Want sex now." Female desire is much more context-dependent. Research by sex therapist Rosemary Basson, whose work fundamentally changed how we understand female sexuality, showed that for many women, desire does not precede arousal. Arousal precedes desire. What this means practically, many women do not wake up spontaneously craving sex. They begin a sexual encounter feeling neutral or even mildly resistant. And then, as arousal builds, desire follows. This is responsive desire as opposed to spontaneous desire, and it is completely normal. It is the dominant model of sexual motivation in the majority of women. Why does this matter for low libido? Because a woman who expects to feel spontaneous desire, who is waiting to feel like it before initiating or agreeing to sex, may wait a very long time. She may interpret her absence of spontaneous desire as the absence of desire entirely. She may label herself as having low libido when what she is actually experiencing is a normal pattern of responsive desire in a context that is not optimally stimulating. This is not a solution in itself, but it is context that changes how the problem should be framed. Now let's go through the most common medical and lifestyle drivers of genuinely diminished libido in women. The first is hormonal, specifically estrogen decline. Estrogen has a direct role in sexual function. It maintains the health of vaginal tissue, keeping it lubricated, elastic, and sensitive. When estrogen drops, as it does during perimenopause, menopause, postpartum recovery, and in women using certain hormonal contraceptives, the vaginal tissue thins and dries. Sex can become uncomfortable, sometimes painful. And when sex is associated with pain or discomfort, the brain learns to suppress desire. Why would your body generate desire for something that hurts? This connection between vaginal dryness, pain during sex, and low libido is one of the most underdiagnosed loops in women's sexual health. A woman presents to her doctor saying she has lost interest in sex. She may not mention that sex has become uncomfortable because she assumed it was just another part of the same problem, or because she felt embarrassed to raise it. The doctor may prescribe antidepressants or recommend therapy. The actual cause, estrogen-related vaginal atrophy, goes unaddressed. The treatment for this is straightforward and highly effective. Local vaginal estrogen applied directly restores the tissue without meaningful systemic absorption. It does not carry the risks associated with systemic hormone therapy. It is one of the most underused interventions in women's sexual health. The second hormonal driver is testosterone decline. Yes, women have testosterone. Yes, it affects female libido substantially. Testosterone in women peaks in the mid-20s and declines gradually through the 30s, 40s, and beyond. Women who have had their ovaries removed surgically surgically experience a dramatic drop in testosterone that is often more sudden and severe than natural menopause. Women on certain oral contraceptives may experience suppression of free testosterone through increased levels of sex hormone-binding globulin, a protein that binds testosterone and renders it biologically inactive. Female testosterone deficiency is not a fringe diagnosis, it is a recognized hormonal condition. And in some women, particularly those with documented low testosterone levels alongside low libido, reduced energy, and flat mood, testosterone therapy is evidence-based, effective, and endorsed by major endocrinology societies. It is, however, significantly underdiagnosed and underprescribed. The third driver is thyroid dysfunction. The thyroid gland regulates metabolic rate throughout the body. Both hypothyroidism, underactive thyroid, and hyperthyroidism can affect sexual function. Hypothyroidism in particular is strongly associated with low libido, fatigue, depression, and vaginal dryness. It is also far more common in women than in men, affecting approximately 1 in 8 women over their lifetime. And it is easily identified with a simple blood test. If you have low libido alongside unexplained fatigue, weight changes, hair thinning, or feeling consistently cold, thyroid function should be among the first things your doctor checks. The fourth driver is medication. This is one of the most common and most overlooked causes of low libido in women, particularly in the women most likely to be seeking help. Women in their 30s and 40s who are also managing anxiety, depression, or chronic pain. SSRIs and SNRIs, the antidepressants most commonly prescribed, are associated with reduced libido, delayed orgasm, and anorgasmia in a significant proportion of users. Estimates vary, but studies suggest that between 30 and 40% of people on SSRIs experience sexual side effects. This is not a rare reaction. It is common enough that it should be discussed proactively at every prescribing appointment. The cruel irony is that depression itself suppresses libido, and then the treatment for depression may further suppress it. Women can find themselves caught between two forces working in the same direction. Solutions exist: dose adjustment, timing adjustments, switching to antidepressants with a lower sexual side effect profile, bupropion, mirtazapine, or adding a specific medication to counteract sexual side effects. But none of this happens if the conversation doesn't happen, and the conversation doesn't happen if women don't know to raise it. Hormonal contraceptives, oral contraceptives in particular, can affect libido in some women, primarily through the sex hormone-binding globulin mechanism I mentioned earlier. If a woman began experiencing low libido shortly after starting or changing contraception, this is worth examining clinically. Not all women are affected, and the relationship is complex, but it is real, and it is documented. The fifth driver is stress and cortisol. Chronic stress elevates cortisol. Cortisol suppresses the hypothalamic pituitary gonadal axis, the hormonal cascade that drives sexual function. It essentially signals the body that this is not a safe time for reproduction and suppresses sex hormones accordingly. In evolutionary terms, this makes sense. In modern life, where stress is chronic rather than acute, it means that women under sustained pressure from work, from parenting, from financial worry, from relationship conflict, may experience a persistent cortisol-driven suppression of desire that has nothing to do with their relationship or their attraction to their partner. The sixth driver is relationship dynamics, and I want to address this with both honesty and care. Desire is not generated in isolation, it is generated in context, and the context of a relationship, the history, the communication patterns, the unresolved tensions, the presence or absence of emotional safety directly shapes sexual desire. Research by psychologist Marta Meana and others has consistently shown that a significant driver of female desire is the feeling of being desired, not just liked or loved, actively, specifically desired. In long-term relationships where partners are deeply familiar and the erotic is often replaced by the domestic, this specific feeling can erode. The relationship may be loving, functional, even genuinely happy. And yet the context for desire has changed. This is not a moral failing. It is a documented psychological and relational dynamic that can be addressed through intentional changes in how partners create erotic context, and often through couples therapy focused specifically on sexual dynamics. There is also the issue of accumulated resentment. Unresolved anger and low-grade resentment toward a partner is one of the most potent desire suppressants in long-term relationships. It is physiologically difficult to feel open to intimacy with someone toward whom you carry unprocessed grievance. This is a relational issue, and its solution is relational. Communication, conflict resolution, sometimes professional support. I want to tell you about a patient I'll call Diana. She was 36 years old, a teacher, married for 8 years, mother of 2 young children. She came to me saying she had not initiated sex in over a year and had begun declining her husband's advances more often than not. She was not unhappy in her marriage. She described it as good, genuinely good, but she felt nothing when it came to sex. She described herself as broken. Her thyroid was normal, her estrogen was beginning its perimenopausal decline, her testosterone was low normal, but what emerged as we talked was something more revealing. She had not slept more than 6 consecutive hours in 2 years. Her days were structured entirely around meeting other people's needs, her students, her children, her husband. By the time she reached the end of the day, she described feeling that her body was not her own anymore. The idea of someone else touching her, needing something from her, even lovingly, felt like one more demand on a depleted system. This is something I hear consistently from mothers of young children. The physical caregiving load of early motherhood, the constant holding, nursing, touching, carrying, can generate something called touch saturation. The body's need for physical space and autonomy is fully met, exceeded actually, by caregiving demands. And in that state, the desire for physical intimacy as a form of receiving touch is replaced by a desire for physical space. Diana didn't need medication. She needed structural change, dedicated time in her week that was entirely hers, sleep protection, a conversation with her husband about the asymmetry in domestic and caregiving labor that had developed since having children. When those changes began to take hold over the following months, her desire returned, not dramatically, not overnight, but steadily. The lesson I want you to take from Diana's story is not that her libido problem was just stress or just relationship dynamics. It is that low libido is rarely a single cause phenomenon. It is almost always a layered interaction of hormonal, psychological, relational, and lifestyle factors. And addressing it requires looking at all the layers, not just the easiest one to prescribe for. So what does seeking help actually look like? First, a proper medical workup. This includes thyroid function, hormone panel including estrogen, progesterone, testosterone, and sex hormone-binding globulin, and a review of all current medications for known sexual side effects. Second, a conversation about symptoms beyond libido. Vaginal dryness, pain during sex, difficulty with arousal or orgasm, these are often part of the same picture and deserve to be discussed. Third, if no clear physical cause is identified, a referral to a sex therapist or psychologist with training in female sexual health. This is not a consolation prize. It is frequently the most effective intervention available, particularly for desire discrepancy in couples and for the psychological drivers I've described. Finally, patience with the timeline. Libido changes that have developed over months or years do not resolve in 2 weeks. Most effective treatments, whether lifestyle, hormonal, or psychological, require a sustained approach over weeks to months before meaningful change is seen. What I want every woman watching this to walk away knowing is that low libido is not your fault. It is not proof that you are no longer a sexual person. It is not a measure of how much you love your partner. It is a condition with causes. And those causes can be found, named, and in most cases, treated. You deserve a doctor who takes this seriously. You deserve a conversation that goes deeper than, this is just how it is sometimes. You deserve to understand your own body. I'm Dr. Maya Roa. If this video gave you language for something you've been feeling but couldn't name, tell me in the comments. That comment might be the most important thing you do this week. Share this with a woman who needs to hear it. And subscribe because we're just getting started. Take care of yourselves.